Okay, I think we'll get started with the seminar presentation today. Hi, everyone. I'm Rob Murphy, and I'm the Executive Director here at the Havey Institute for Global Health and the John Fair Professor of Infectious Diseases and Professor of Biomedical Engineering at Northwestern University. Thank you for taking the time to join us this afternoon and for our latest installment of the Havey Institute for Global Health IGH seminar series. The title today is Cervical Cancer Elimination Agenda in Nigeria Towards 2030, Prospects and Challenges. Please take a moment to follow us on LinkedIn and Facebook, as well as Blue Sky and Instagram at hashtag FSM Global Health. In addition, we welcome you to become an Institute member, which takes approximately 30 seconds, to receive access to specialized resources and services that support research infrastructure. For more information, and to sign up, you can visit our website, pretty easy, globalhealth.northwestern.edu/members. The AV Institute for Global Health is thrilled to host our longtime collaborator, Imran Morhason-Bello, at today's seminar. Imran is a professor of Obstetrics and Gynecology and an adjunct research fellow at the Institute for Advanced Medical Research and Training at the College of Medicine, University of Ibadan. He's an honorary obstetrician and gynecologist at the University College Hospital in Ibadan, and also adjunct professor at the National Institute for Cancer Research and Treatment in Abuja, the capital of Nigeria. He has clinical and research interests in women's health, focused on pelvic medicine and reconstructive surgery, gynecological oncology, and global health, all of which have influenced policies, best practices, and programs. He's published widely and has secured grants. He's the co-PI or MPI of our R01 grant with Li Feng Hu, who's also joining with us today. He's currently the project director of a multidisciplinary team of researchers under the auspices of the HPV Consortium at the University of Ibadan, Nigeria, on various funded grants, as I mentioned, covering epigenetics, genomics, implementation science, a mobile truck clinic that was a program that recently started in the last year or so, which does cancer screening, sexual behaviors, and national evaluation on HPV infections and related cancers, including vaccine screening and treatment. So we are going to have a Q&A period at the end. We ask that you put your any question at any time during the conference in the Q&A feature, which is it should be at the bottom of your screen, or if your screen isn't big enough, just hit more and it'll show up there. Please put your questions there, and Li Feng will be doing the questions. So now I'm going to turn it over to Imran, Dr. Imran Morhason-Bello, and he's going to give us a presentation. Thank you, Imran, for joining us today. We really appreciate it.
Thank you so much, Professor Rob Murphy, for your introduction, and it's a delight to be here this, well, I would say afternoon, since it's Chicago that is hosting, but it's 8 o'clock Nigerian time. And I want to especially acknowledge the leadership of Institute for Global Health Northwestern, and also Director for Center for Global Oncology, Li Feng Hu, who have been working with, and all the other administrators within the Institute. My talk will focus on the current effort by the government of Nigeria to put Nigeria on the right trajectory for cervical cancer elimination. And I will look at this in the context of Nigeria, because this is a global audience. I will talk about brief epidemiology, situating Nigeria within Africa and global system. We look at natural history. Why is Nigeria having a high burden of cervical cancer? And cervical cancer as a disease of inequity within the country. What is the elimination plan? What are the current approaches, prospects, and challenges? And I will end with some recommendation as an insider and conclude. So Nigeria is a highly heterogeneous in culture, language, belief, and social system. So unlike many countries of the world that are monolithic, Nigeria has over 200 ethnic nationalities that speak different languages, have different culture. We have different religion, and of course, social system in terms of interactions or as a human being. But we have a young population set. The poverty level is high. Majority of Nigerians live below the poverty line. The literacy level is low. In fact, Nigeria has the highest out of school according to UNESCO. And of course, we have a fragile health system. I know the current administration is trying their best in terms of revitalization of the primary healthcare system. As of the last time I have a figure, it's about roughly below average, I think about 46, 47% functional. There are high infection rates, so there are other competing priorities to cervical cancer. But of course, Nigerians are usually hardworking people. We are brilliant, and we are also happy people where we demand less from our leaders. In terms of population, Nigeria is probably the most populous country in Africa with a population of nearly 240 million. Growth rate of about 2.4% with a median age of about 18 years. And of course, in terms of rural urban, it used to be 50%, but there is now a tendency for migration into urban setting because of insecurity and also climate change. And of course, the density per kilometer is over 260. Current National Demographic Health Survey 2024 show that Nigerian women are disadvantaged in decision making, and they often rely on others. So if we look at the key household decision making, you can see that it's only when married women wants to go and visit their family that they begin to have some form of balance in terms of their decision to take an independent decision. But if you look at the health issues, household purchases, they are below average. In other words, an average Nigerian woman married cannot independently take decisions for her health. Now, HPV-associated cancer is real, and cervical cancer is the most common of them all. Nearly 99% of cancer of the cervix is caused by persistence of HPV. In Nigeria and globally, it remains a public health challenge. More than 500,000 women are diagnosed every year, and more than 250,000 are associated with death, and majority of these deaths occur in low and middle income countries. So by calculation or by estimates, every 2 minutes, a woman dies from cervical cancer. And of course, in absolute population, Nigeria contributes to this global body. Now, if you look at countries of the world in terms of, this is Nigeria here. Nigeria is among the countries where cervical cancer is the second most common cancer after breast cancer. And in terms of in relation to other cancers in women, you can see that breast comes first before cervix. Now, in terms of proportion, when we look at prevalence of cervical cancer in the last 5 years, the proportion shows that Nigeria has a number of the prevalence of between 3.8 to 5.8 per 100,000. In terms of the estimates proportion within African setting, Nigeria is about the 38th among the 50 countries that are estimated in Africa, behind Eswatini in terms of prevalence within the population. Now, what is also important is that cervical cancer is more common in resource poor setting that is defined by Human Development Index. And I will show this in subsequent slide, why Nigeria is also regarded as a low middle income countries. Although many emerging data are now coming to say that Nigeria has graduated to middle income country in terms of economic indices, but in terms of practical indices within the health system, Nigeria can still be referred to as low income setting in terms of indicators. Now, I will talk about in terms of new cases, Nigeria is medium. In terms of age standardized incidence rate is between 11 to 17% as against the highest countries of the world that are 25 per 100,000. In terms of comparison, again, Nigeria is in 32 position relative to Eswatini and Egypt. That is the lowest in terms of incident rate comparison to other African countries. In terms of cumulated risk, throughout the lifetime, again, Nigeria is medium between the highest in Gambia, and Nigeria is around 34 among the 50 countries in Africa. So in terms of cumulative mortality, if somebody has cervical cancer, what is the chance that the person will die from that disease? Again, Nigeria has a medium risk within the global community, and of course, within the African community, it's also medium. Now, so what drives the burden of cervical cancer? One of the things that drives the burden of cervical cancer is HIV infection. And cervical cancer is most frequently detected in women living with HIV/AIDS. And that's why in the early days of HIV, it's one of the AIDS-defining illness, because we do know that the risk increases when women have HIV, the risk of acquiring HPV infection, the risk of progression to precancer. In fact, the latency period between the acquisition and persistence is halved among HIV population relative to general population. And the burden of cervical cancer among HIV is highest in sub-Saharan Africa, of which Nigeria contributes a significant proportion. Now, if you look at this publication from Lancet in 2024, Nigeria, again, is medium relative to Eswatini in terms of population, but in terms of absolute number, Nigeria has contributed a significant proportion. Now, how can we best describe Nigerian women within the context of cervical cancer? Yes, an average Nigerian women are hardworking. An average Nigerian woman is the one that take care of the family, is the one that ensure that the family is fine. They are the primary producers of health, and they constitute about half of the population. And if you look at the population of women within the context of the current population of Nigeria, nearly 60 million of them are at risk of developing cervical cancer. And estimates show that 22 women die daily from the disease. And of course, they also have the risk increased, particularly when they are HIV positive. Now, what is the burden of HIV? We also need to put this in context. The last survey done showed that the prevalence is between 1.3 to 1.4. One would think that this is a small population, but in terms of absolute numbers, we're talking about nearly 2 million people living with HIV/AIDS. The access to ART is almost 90%. And of course, despite that, we still have high rates of new HIV infection. So I will say that every year, nearly 1,300 women are diagnosed with cervical cancer, and nearly 8,000 of them die from the disease. And majority of them present in advanced cases when treatment is no longer the primary outcome of care. And of course, we do know that women in Nigeria have high rate of cervical, high risk HPV infection, and in absolute time. And of course, the cervical cancer that we see, majority of them are associated with HPV 16 and 18. Now, this is a review of burden of HPV-associated cancer, although it was done almost 10 years ago. That is the data that we have in terms of looking at the cancer registry in Nigeria. Of course, if you look at most of the cancers, the cervical cancer relative to other HPV-associated cancers, almost 100% of all cervical cancer that are in our registry is caused by HPV. And of course, the population attributable fraction is around 392%, and age standardized ratio is about 28.3 per 100,000. 9 out of 10 cases of HPV-associated cancer is due to cervix. So cervix is the big problem in terms of HPV-associated cancer. The natural history of cervical cancer is well known, is well described in literature. After the acquisition of HPV infection, what happens is that there's persistence or clearance. And if there is persistence will last for almost 10 to 20 years in general population. In HIV positive, it may be 5 to 10 years before pre-cancer begins to manifest. And then, of course, cancer develops if nothing is done. However, 80 to 85% of women will clear this virus, and it's only 10 to 15% that will persist. So, however, in 2025, the International Papillomavirus revealed the concept of persistence and also the acquisition and transmission and detection in order to obviate the challenges of the contamination that's often wrongly reported as infection. So they come up with the concept of the latency period and the reversal of the latency period, and of course, detection. So it's possible that depending on the platform that one is using, if a woman may be found to be positive on a platform, on a particular platform today, tomorrow when you test on a less sensitive platform where this the detection rate is of the CT value is higher, then that woman may be found to be negative. And then, of course, if a woman has just recently had sex, she may be having the DNA of the HPV of the partner, whereas she doesn't have the infection. So these are what was talked about in terms of auto-inoculation, viral detection when it is lower, concept of reinfection and acquisition. This is very important because this affects national values that have been quoted, and it's one of the things that we will be looking at shortly. So what happens in terms of progression? This is a very nice cervix showing the ectocervix and the endocervix and the squamocolumnar junction. If there is a acquisition of HPV infection, the HPV persists and nothing is done, then there is precancer. If nothing is done to precancer, it leads to an ugly situation of invasive cancer. Now, there's a recent systematic review of a meta-analysis of data of about 100,000 women that include data from Nigeria in terms of looking at HPV, high-risk HPV that are associated. This is very important to also understand the intervention that Nigeria is doing and see whether it's a prospect or a challenges. I'm putting this slide here to let you realize that there are a bunch of high-risk HPV that are detected in Africa, particularly HPV 35 that is here. And I must say that different publications have shown that in healthy population, high-risk HPV 35 is the commonest. As I will show in subsequent slide, they also cause cancer. And unfortunately, this high-risk HPV is not in any of the current candidate vaccine that is being used globally. So this is another meta-analysis published last year in West Africa, of which more than 70% of data in this publication are from Nigeria. And it did show that despite the pattern of the HPV that are seen in the cervix, not all the HPV detected in West African women, particularly Nigeria, were covered by even the non-valent HPV vaccine. They only cover about 63%. So this is the breakdown of this publication. 6 out of the 7 of most common HPV are within the non-valent. But if you look at Nigeria, in terms of coverage, you will see that HPV 35 is there. It's not covered. And about 14.3% of women that have invasive cervical cancer have HPV 35. In other words, these women will, how will they benefit? Of course, there's argument that in terms of cross-protection, but we all know that data on cross-protection has not been as categorical as data from the vaccines that women received. So This is a meta-analysis that we are also currently conducting. We're about to publish. It shows that women in Nigeria have 40% of women sexually active have any form of high-risk HPV infection, and nearly 28% of them have high-risk HPV infection. In other words, if they don't clear, these 28% don't clear, they run the risk of developing cervical cancer. And in terms of the breakdown of the high-risk HPV infection, you also see here that almost 6% in the healthy population have HPV 35, and they have all the other HPVs that are not in any of the candidate vaccine. The one I highlighted are those that are in the non-valent vaccine, which is the most valent of all the vaccines globally. Unfortunately, Nigeria is using the tetravalent vaccine for the national program. Now, this is the paper that was published by Professor Adewale and some of his colleagues called the FWACS study. The study showed that this was using histology samples, using the frozen samples of cervical tissue in Nigeria, Ghana, and South Africa. And you can see here that the third most common HPV within this cancer tissue is HPV 35. It even comes ahead of HPV 45 for adenocarcinoma. And if you look at it in terms of the cancer breakdown on the right here, you can see that it associates with 9%, almost 10% in the squamous cell, and then, of course, in adenocarcinoma, about 4%. Now, one must understand cancer control from the prism of public health, that each of these interventions can be largely broken down into primary prevention, which is promotion of health and lifestyle behaviors, vaccination, the secondary prevention, that is early detection through screening and early diagnosis, and of course, tertiary prevention, which provide the timely treatment and supportive care. This prism is very important for any country that aims to go for elimination agenda. The World Health Organization muted this idea in 2018 and 2020. They came up with this strategy of 90-70-90 agenda as a vision of a world where cervical cancer is eliminated as a public health problem. In other words, a country will be able to talk about incidence that is less than 4 per 100,000 of the population. And what are these strategies? 90% of girls should be fully vaccinated by age 15. 70% of women are screened with a high performance test by 35 and 45 years of age. And 90% of women identified with the disease should be able to have access to treatment. At least if the World Health Organization believes that any country that is serious, even if we are a low resource setting, you should be able to go for this strategy. It's a life cost thing. It's a life cost in the sense that before a girl achieves sexual debut, we need to introduce some lifestyle information. For example, sexual health information. Sexual health information in countries where sexual health is a contested word to be discussed openly. For example, Nigeria adopted what is called Family Life Education Program, where girls are introduced to the biology of the reproductive health system. And then, of course, they talk about sexual activity in a very subtle way. And of course, they also talk about, in terms of, for those that are sexually active, how to protect themselves. Countries that are determined for elimination, we also need to come in with immunization before age of sexual debut, roughly around 9 to 14 years. And then, of course, secondary prevention for those that are sexually active, screening using high-performance tests, and then, of course, followed by treatment of those that are positive to high-risk HPV or they have evidence of lesion. And for those that are discovered to have invasive cancer, now they need to have a comprehensive multidisciplinary treatment that may involve surgery, radiotherapy, chemotherapy, and for those that come in late disease, there should be opportunity for palliation. So Nigeria in 2017, as part of its strategic approach to look at cancer holistically, established an institution called National Institute for Cancer Research and Treatment, NICRAT, as a corporate organization, as a corporate entity that is reporting to the Minister of Health of Nigeria. And this institute has a director general, has different departments, including clinical, including programs, research, and etc., monitoring and evaluation. They look at different cancers, including cervical cancer. And to further driven this down, the government of Nigeria in 2024 established the National Task Force on Cervical Cancer Elimination, chaired by a former Minister of Health, a gynecologist, Professor Isaac Adewale, co-chaired by Dr. Zainab Shinkafi Bagudu, who is the president-elect of UICC and also an advocate for cancer care and the wife of a former governor. So the task force mandate is to accelerate Nigerian progress to achieving the World Health Global Cervical Cancer Elimination Strategy of 70-90 agenda by 2030, and this task force has begun work immediately. So what are the things, the mandate? The mandate of the task force is to look at cervical cancer as a life-cause disease. What happens before acquisition of the virus? What happens when the virus is acquired? What happens when the pre-cancer is acquired? What happens when the real cancer happens? And of course, for those that have had the cancer and survived it, what happens to them? How do we contextualize all this within the Nigeria ecosystem? So the task force focused on 4 strategic areas. 1, service delivery and capacity building, communication and public health awareness. How do we monitor data in terms of monitoring and evaluation? And how do we use this data to generate new research questions in terms of research and innovation? How do we mobilize resources in terms of advocacy and sustainability? Nigeria is beginning to look at a situation where the country will be able to be self-sufficient and not develop or not depending on international donor for her implementation. So the task force has almost about 11 to 12 subcommittees given with responsibility to look at different aspects of this life course. And of course, the task force started its work almost immediately by engaging with all the critical stakeholders. One of the chief technical partners that the task force visited is the World Health Organization. As we know, they are like the technical team for virtually all governments of the world in terms of United Nations. So, and they are represented in every country. So it is very strategic that the task force is leveraging on this partnership. And of course, the subnational, as many of us who know, Nigeria has about 36 states. We run almost the same type of government like American system. We have the federal government, the state government, and then the local. And of course, the governor also has a secretariat similar to what obtains in the United States. They have the Nigerian Governors Forum, the secretariat where the governors meet and do a peer review of their activities. So as part of the recognition of the importance of the private sector, the task force also partnered with the private sectors, and the logo here is endless, is an old one. I'm sure there are more partners. So under the auspices of Partnership to Eliminate Cervical Cancer in Nigeria called PESIN, this was launched by the wife of the president. That is the highest political mileage that we pulled. And this effort was to focus on 2 objectives. 1, how do we drive the subnational government to coordinate expansion of cervical cancer elimination activity? Federal government cannot do it alone, and government is, as we go down the ladder of governance, they are more closer to the people in terms of implementation. That's number 1. Second, how do we foster multi-sectorial collaboration and coordination? Nigeria benefited maximally from the private sector during the COVID pandemic. And as a matter of fact, they were major players in terms of capital funding and resource mobilization. So we're also leveraging on this. And this is why, and since that time that the task force engaged with this private sector, it has become a real and enduring sustainable partnership, because we now meet regularly, nearly every Friday of the week, between the hours of 9 and 10 in the morning, where we discuss critical issues that will push the agenda of cervical cancer elimination in Nigeria. Now, documents were launched, and this document, the first document that was launched is National Strategic Plan for Prevention and Control of Cancer of Cervix. And of course, these documents has a lot of information there. If you need to convince any donor, you need to convince anybody that you want to partner with you, you have to talk about the burden of the disease. You have to talk about why is it important to invest? What is the return on investment? And of course, we need to create awareness and mobilization. And we also need to craft our communication strategy in order for it to be context specific and to resonate with the Nigerians who will be the end users of this. And of course, there are issues around prevention and control measures, survivorship, governance and leadership at all levels of government in the country. And then how do we monitor, evaluate, and learn? And of course, develop research that will further make us to understand the challenges associated with cervical cancer as we move along the pathway of elimination. Some of the strategies that we have identified as a task force for the country include community engagement. How do we how do we ensure that we sustain the gain of HPV vaccination, which I will talk shortly? How do we enhance the screening program in order to have a national population screening that will be effective and efficient? How do we develop and also sustain our infrastructure for treatment for those that are found to be positive? And of course, we need the manpower to ensure that, and this is well developed across the value chain of the health system. And how do we strengthen diagnosis so that we will ensure that our registry have adequate record? Now, this is the graphics. The photograph on the left here is the stakeholders that developed the guideline, and then of course the launching of the document by the wife of the president here, and then of course the Minister of Health that is in charge of the cervical cancer, of the cancer control in the country, and of course the chairman of the task force. So what are the practical steps from the current cervical cancer elimination policy in Nigeria? The first is that the practical thing is that Nigeria invested heavily, and we are gaining from it in terms of primary prevention. The campaigns, when the vaccination was introduced more than 2 years ago, Nigeria vaccinated over 15 million. That is the highest in any part of the world at a time. And I'm learning now that we are almost hitting 17 million girls that have been vaccinated. This population is more than many absolute population of many countries in Africa, the number of girls that have been vaccinated. And again, I'm happy to also let you know that Nigeria has now routinized the HPV vaccine. So one can walk to any of the infant welfare clinic now to get a girl vaccinated. I'm sorry, I'm saying girls because we are doing girls only, single dose HPV vaccination. Nigeria has not been buoyant to say we want to do a gender neutral vaccination. Now we have some current realities during the campaign, and Nigeria surmounted that challenge. One of it is that we have high out of school eligible girls. Outreach outposts were created for out of schools, and these girls were also vaccinated. And of course, there were pushback from the anti-vax organization. This affected some states, particularly Lagos State, during the initial rollout. But of course, the government responded by providing a pushback to this anti-vax, and it's a delight to hear now that Lagos, the coverage has now moved up, and of course, the accountability and responsibility that was set up by the National Primary Healthcare Development Agency of Nigeria has also helped drastically. That's one thing that, at least that's one of the good things that Nigeria is proud of in the international community. This is just showing the outlay of state by state. And you can see Lagos State here, 36% during the campaign, because there was a high level of, they have a challenge during the rollout. But like I said, this was promptly controlled after the government stepped in to correct all the misinformation. Now, this is the evidence to show that Nigeria is on the right track. So this is one of the prospects. This is a modeling that was a mathematical modeling that was done. Credits to MSD that shared this slide with me when I was discussing with them. It was a 4-country analysis comparing India, Vietnam, Uganda, and Nigeria. And there were 2 scenarios, 2-dose nonavalent versus with 80% vaccine coverage rate, whether we do single girl, whether do girls only or gender neutral. And you can see that with vaccine alone, you can halve the time to achieve herd immunity and elimination if we do gender neutral. But like I said, we need to also look at other competing priorities. But it did show that if Nigeria use nonavalent relative to tetravalent, we may begin to fast track our journey towards elimination. Now, what about the secondary prevention? During the stakeholders meeting, one of the things that we quickly discovered when we look at the evidence is that what WHO is advising the whole world is the way to go. We don't have to do it half measure. So HPV DNA testing was adopted as a method of choice. And then we now need to consider the issue of access, infrastructure, capacity building, screening approach, and the model, whether we want to do see and treat or want to pull sample together, and then people that are positive are invited for treatment. And then, of course, there are other things, other demonstration that is going on, use of mobile clinic, which I will talk shortly. Nigeria adopted self-sampling as an option of sample collection because of challenges of manpower. And then, of course, we are also looking at the possibility of engaging nurses and community extension workers in primary healthcare as a form of point of entry for screening program. Nigeria actually is signatory to tax shifting and tax sharing policy. Now, as part of the elimination agenda, the task force agreed to do a phased presentation, a phased implementation. And I'm happy to announce that the rollout will soon start in 2 states, Southeast, Imo State, and then Niger State. And I believe that this effort will break the jinx of a long waiting period of not having a national screening program. So different platforms are being considered. Like I mentioned, Cobos, that is from Roche, is one of the platforms that we're going to be using, which we do tests for high-risk HPV 16.
Imran, I will give you 10 more minutes.
Yes, I'm rounding up. And then, of course, the extended genotyping that will allow, that can also be used in other settings. Now, self-sampling, we're using it, and it brings innovation. It reduces the risk of low waiting period. And of course, evidence show that the quality of sample collected between clinician and self-sample is the same. The quality of DNA is the same. The pattern of HPV collected is the same. So therefore, why should Nigeria not leverage on that? Nigeria has also mapped out infrastructure in terms of centers that are available, primary healthcare center. We know facilities. We have also mapped out general hospitals. We know that we have high number of teaching hospitals that could act as a mentoring, particularly when we pick cases of precancers that cannot be managed with thermal ablation, that may need LEEP, you may need to now have a gynecologist and tertiary institutions. And one of the innovation that the task force is also bringing is that the teaching hospitals within the state will act as mentor to facilities. Tertiary institutions cancer centers, the federal government is trying to establish some cancer centers. I'm aware that the coordinating minister of health has commissioned about 3 cancer centers that can offer chemotherapy. The radiation centers are being increased. And of course, we're also partnering locally with through the West African College of Surgeons and National Postgraduate Program to have subspecialists that could act as gyne oncologists. Efforts are on the way to also partner at the national level with the International Gynecologic Cancer Society in terms of capacity building. And these are started in some teaching hospitals in Nigeria. What about the role of digital health? Digital health will help, and this is in terms of development of app. There are some applications that have been developed that can self-instruct women on sample collection. And this is something that we need to be tested at a higher level. And of course, I'm aware that the FICS Consortium are currently using automated detection of algorithm for patients after triaging those that are positive for HPV. This has been tested, and Nigeria was part of this, particularly in Ife, through Dr. Jenny Fuja. And what are the benefits of bringing digital health? The thing is that may improve access, will reduce the risk of loss of follow-up. Our data system will be able to coordinate it. Real-time monitoring is possible. And then, of course, it will fast-track access to treatment. Now, there are some demonstration projects funded by the NCI in Nigeria. And one of them is West African HPV-based self-sampling, of which Professor Li Fang Hao is the contact PI, of which JOS, that is being led by Professor Jonah Musa and myself from Ibadan, where we have looked at self-sampling scenarios, HPV DNA testing, the same-day treatment within the HIV setting. And the result is promising, where women are willing to accept this, and this is a point that the task force can take up for implementation at a national level. What about other innovation? Medicaid here started the idea that we need to reverse medical tourism by linking Nigerians who are living with pre-cancer to specialists without leaving the comfort of their home. This is something that could be leveraged upon as we develop our manpower. And of course, the use of mobile truck clinic that we are currently partnering between the Northwestern and the Center for Global Oncology and Northwestern University and University of Ibadan. So far, over 2,500 women have benefited from screening, self-sampling, treatment, and treatment on the same day. And in fact, we have gone as far as 4 to 5 hours from our station, and these women are treated the same day. Now, what is the funding landscape for cervical cancer in Nigeria? It's an area that is not yet resolved. Should we do institutional funding or outsourcing to those that will provide this service? How do we bring in the National Health Insurance Authority into this? I know it's within our insurance scheme that we should screen for cervical cancer, but to what extent? All these discussions are ongoing, and I believe that this will be driven by evidence. Governance and leadership is something that will fast track the cervical cancer elimination agenda in Nigeria, but this will include how do we handle logistics, how do we handle technology, how do we handle health workforce. The incessant disruption by conflict within the health sector, how do we ensure and minimize this to avoid it being destructive on the plan for cervical cancer elimination? This is one thing, one reality, and one problem that we have to face. So in total, the task force has done the costing. That how much will it take us to ride into 2030? And if you look at this costing, they are very staggering. And one thing that is very clear is that the primary prevention and secondary prevention are multiple of the amount you need to treat. In other words, if you focus on primary and secondary prevention, it will get more population, but it's at a cheaper rate. So I don't think Nigeria can afford $105 billion US dollars to treat everybody that will need cervical cancer care. But what we can do is that we can sustain the gain of our primary prevention and then be diligent on our screening program and rolling out process so that no woman will be left behind. So in other words, as we do this, we need to put in monitoring and evaluation. We need to cost. We need to look at cost effectiveness of different strategies and approaches that we're using in order for us to gain and learn from this, and then, of course, reduce this burden of cervical cancer as we move. One thing that is also important is that community needs to be carried along. We need to mobilize and engage them. We need to co-design. Nigeria is very complex in terms of sociocultural setting and acceptability. So this has to be contextualized within each of the states that will continue to roll from. And that's one of the reasons that informed the task force to do a phased introduction of the screening program. So in conclusion, I will say that Nigeria, like other low and middle income countries, has potential to reverse the burden of cervical cancer and begin the process of elimination. The task force has commenced the process after mapping and engagement of critical stakeholders at national and subnational level. Policy implementation using practical, visible, and innovative solutions will fast-track the process to achieve this elimination. Active investment on material and non-material resources is essential. And Nigeria, I believe, Nigeria is on the right trajectory for cervical cancer elimination. I want to especially thank the HPV Consortium, of which I am working with. These are the team members, the investigators, and our young dynamic staff who are brain behind the production of these slides. And then, of course, I want to thank everyone. Thank you for listening.
Well, thank you, Imran. It was a great presentation. We have time for some questions, so if you could put them in the Q&A box at the bottom of the screen. Li Feng, you're going to lead the Q&A discussion.
Yes, and thank you, Imran, for and outstanding presentations. It was very informative. Now we open to the questions.
I can jump in with a question. I'm not able to add it into the Q&A, I think, as a panelist. But Imran, it's so amazing and impressive to hear about the development of the National Institute, the partnership, and the task force. And I wanted to hear a little bit more about how those three new entities interact with each other, and the kinds of deliverables that they have and how they may also be similar or different from each other.
Okay, thank you, Kate. The National Institute for Cancer Research and Treatment, like I said, is an agency of government established by law. The task force was established by the Minister of Health in consultation with NICRAT. So the task force secretariat is actually within NICRAT. So, so more like a government agency setting up a task force to kickstart a health agenda they superintend over in order to fast track the process. So so we're complementary. So the secretariat is within NICRAT, the task force within NICRAT, and a director that is represent the Director General on the task force. So I don't know whether I answer your question, Kate.
Yes, thank you. That's really helpful.
We have questions coming in. First question is by the director for our primary care, Dr. Lisa H. Huang. Please don't be upset at me if I pronounce your last name incorrectly, Lisa. So the question is, she first said excellent, inspiring presentations. Her question is, what challenges do you anticipate across the different states, and if and how strategies may need adapting? Very good question. Actually, this is what I was thinking of asking. Thank you, Lisa.
Thank you, Lisa, for this question. And I think so. One of the things that the task force did in terms of rolling out in states is the process of co-designing their plan for rollout in their states. So states are were allowed by the task force to come up with their own approach, and why the task force is providing the technical support because of the expertise that are within the task force. So the co-designing and co-production will contextualize individual states. That's number one. Number two, we are also test running different screening platform approaches. The idea of collecting samples and then batching and doing mass testing, and then returning the test to the women, and then calling back those that are positive for treatment. In other words, follow-up. Whereas in another states, we're testing using HPV platform with the possibility of treating them the same day if they are, for those that are tested that found to be positive. That's one. The sociocultural setting also differ. In the South, generally speaking, I say generally speaking, not all, that South may be more liberal, and then in terms of engagement of healthcare workers, and then in the North, you may have to be more sensitive to a gender-specific or sex-specific providers that we interact. So in terms of operational, the health system, in terms of the strength and the capacity, workforce and experience may also differ between the different states. So these are some of the issues that may spring up. And of course, since we started in terms of partnership between the task force and the state government, I see that it will be the challenges will be solved in a very collaborative way. But definitely there will be some specific challenges across the states.
Our next two questions actually asked by the same person. I think Dr. Oli Inka Isemi. He has two questions, or she. He said, I read that the self-sampling using urine sample is cheaper. Are you considering this, meaning using urine sample? Another question is, if local NGO and community-based organizations are involved, how can they be part of this?
Okay, thank you, Professor Ilesomi, Olayinka Ilesomi. Very well, evidence has shown that first void urine has a high concentration of cervical vaginal secretion that you can use to detect. I must say that, yes, this has been validated in some settings. Some studies have been done, particularly by the Belgian team, and a few African countries have done it. So it's a possibility, but one of the big challenges around it is the plastics that comes with it that they are still trying to refine because of issue around environmental issues. But it works, and it's a potential screening that when it is finally refined, I don't think what the task force is saying is HPV DNA testing. They are not talking about the medium of testing it in terms of whether it should be swab alone or whether you cannot use urine, particularly if you want to do it in a frightful person that doesn't want to insert something in there. So it's an evidence waiting to be adopted. I think I will leave it there. In terms of engagement of community-based organizations that are involved, yes, the Partnership for Elimination for Cervical Cancer in Nigeria is a public-private partnership. Community-based organization can be involved. For example, they would need to mobilize in the states. I don't know where CBOs in the states will be engaged because they will be involved in mobilization. They will be involved in sharing, creating awareness about the screening program. They will also be involved in the logistics within the state. But at the national level, the national is not implementing, it's the subnational that will implement, the local and the state governments, and then of course within the localities. So I will employ the CB organizations that are interested to reach out to the governments, particularly office of the commissioners in their states, to get involved. And I think it will be a rewarding thing to be part of it and to collaborate with government as this program is being rolled out.
I think since we're at the top of the hour, I think
we have one more. Let me.
one more. Go ahead.
Claudia
Yeah,
asked.
Claudia Hawkins. Yeah, sure.
So this is from our Communicable Disease Center Director. Claudia asked if there is a clear, strong national commitment to cervical cancer prevention in Nigeria. Thoughts on how the infrastructure and policy frameworks established for this effort efforts be leveraged to advance prevention of other vaccine preventable cancers in the country. If HPV, for example, HPV associated liver cancer. So.
Okay, yes, I get the point.
You are fast.
Any infectious disease person will look at multiplex kind of a platform that you can use because of limited resource setting. Yes, Claudia, that's a very good point. Many of the platforms that are now beginning to be used for HPV genotyping, I'm also aware many of them are undergoing validation for hepatitis. And these can be a game changer because, as you rightly mentioned, HPV-associated liver cancer is also very high in many of the LMICs. So, and I think leveraging on this setup, for example, one of the infrastructure we are leveraging on is the COVID infrastructure. When we're looking at the potential laboratories that can be used for HPV genotyping, one of the things that came to mind is that, where are the molecular labs that we used during the COVID? And then these laboratories are now being used and they are being considered, will be considered in the States for either redesigning or adding some form of equipment into that to be able to do HPV. So similar for HPV. And HPV co-infection is something that is very common.
May I ask one question? I really want to ask this one.
Very quick.
Yeah, very quick. Yeah. So, and Imran and Professor Isaac, I saw is also on, I think, the leader behind all this strategy development and also implementation. Imran, my question is, I know many other African countries, not many, several of them also have their national structure or national efforts to eliminate cervical cancer. What do you think is the uniqueness or unique features of Nigeria National Task Force, and that you think Nigeria is going to be successful and do very well?
Why I'm confident Nigeria will we do well, the first is the leadership and the political will that we got at the highest level. The chair and the vice chair for the country are seasoned people. The chair is the former Minister of Health. He's a gyne oncologist who understands the disease from science perspective and also have the leverage, the political leverage within the country and the international level. And then, of course, the vice chair, like I mentioned, is the president-elect of UICC, a former first lady of a state who has also gone through the process of cancer control within the. And we're also fortunate that the wife of the president is interested. So now you can see when things are going to be successful, many lights will be turning to green. So you will not have amber color or red. I hope, Lifang, you understand what I'm talking about. Easy passage. So that's one of the things that we go well. Somebody asked me this type of question in the afternoon in another forum where I was talking about HPV-associated cancer. And I did mention political will, picking the right round peg in the round hole. Do not politicize science. When you want to set up this type of task force, you need to look back and pick among the best that are in your country to drive it. Funding will come when there is right political will and the right leadership.
So I think it's
Thanks,
also
Imran.
innovation in technology, programmatic, right? And the strategy, the structure that the leadership has formed. Thank you very much. And
Thank you both for this very incredible lecture. Thank you, Imran. Thank you, Lifang.
thank you,
This
Ron.
concludes today's seminar. Thank you very much to the audience for joining us and for your very thoughtful questions. We invite you to join us at the next Institute for Global Health seminar, co-sponsored by the Patasnak Longevity Institute Human Longevity Lab, taking place virtually by Zoom on Wednesday, April 1st, featuring Nicola Plastow, Associate Professor and Undergraduate Program Coordinator in the Division of Occupational Therapy at Stellenbosch University in South Africa, one of our major partners. And you can register via our newsletter, Planet Purple, and our social media pages. And again, thank you all for joining us today. A recording of the webinar will be available online and will be shared via our newsletter. And this concludes today's webinar. Sorry for going over a couple minutes, but thank you all very much. Thanks again, Imran, for your great presentation.
Thank you, everyone. Yeah, bye-bye.